Good day to everyone. Let me tell you something new about syndesmotic fixation. The purpose of the surgery in case of neglected syndesmotic rupture is to restoration the normal anatomy of the fibula in the fibular notch of the tibia, and holding it in a time requiring for scar formation is about 6 or 8 weeks in every method of operative treatment. Which condition we create for a rehabilitation patient in case of external fixator on his ankle. It is immediately, by bearing immediately active range of motion, axial blood bridging to prevent conflict of the articular surfaces, and control it at any stage of treatment, range of motion. We have 3 stability complexes of the ankle joint to prevent eversion: medial malleolus and deltoid ligament, length and rotation of the external malleolus, and the syndesmotic. And when we have 2 from 3 complexes is stable, all ankle joint is stable. For example, in this case, in case of medial malleolus non-union, it is absolutely a great functional outcome despite the non-union of medial malleolus, because 2 from 3 is intact. So our principles to reduction of the syndesmosis is indirect reduction of the tibia or indirect reduction of the talar dome and ligamented axis of the external malleolus. So Elizarov technique in case of neglected syndesmotic rupture is a self-sufficient method. For example, in this case, 6 months from injury, a closed indirect reduction, hinged variant of the Elizarov fixator, active range of motion and weight bearing on the 2nd day after surgery. This is her gait analysis biomechanics, and this is her final functional and anatomic outcome demonstrating full anatomy restoration of all structures of ankle joint. We absolutely like this methodic. It is a brilliant method, but we hate only one thing. It is a time of fixation. Because it is 12 weeks, it is too long. It is unacceptable for patients. So I show you the way how to reduce this time. Same case, 2 months after blast injury, Chaput fragment, Foltman fragment, and incorrectly positioned fibula in the fibular notch. This is closed indirect reduction in Elizarov fixator, and after from the step incision, we have a fixation of the syndesmosis by suture button fixator. Time of fixation was 6 weeks. This is his gait biomechanics and video analysis, and this is his final anatomic outcome. Next case, the same situation in stable syndesmosis, 2 surgeries before, and now we have a lateral subluxation. So removal of foreign bodies of the ankle joint, fixation of the syndesmotic with the external fixator and suture button. Time of fixation was 6 weeks, and this is anatomical result without a problem. So sometimes we have to reduce indirectly to the talar dome, like in this case, step-by-step gradually reduction is about 1 week, and the 2nd stage surgery is a limited external fixation from step incisions to reduce the time of fixations. Sometimes we use not a suture button fixator, but a bioresorbable screw. It works absolutely the same, and the same result. Time of fixation 60. Here we have 2 variants of the foot fixation. In these cases, sometimes it depends from anthropometric of the patients. Sometimes it is a limited fixation of a 3/4 ring only through the calcaneal bone. Sometimes it is full U-shaped ring and wires into metatarsal bones. So the most important for rehabilitation is properly placed hinges. Sometimes we do it in the surgery room, sometimes we do it the day after surgery under patient's control of active motions. So what is about our rehabilitation protocol? Actually, it is aggressive, immediately rehabilitation and weight bearing as soon as possible, and active range of motion as soon as possible, because it is the main improving functional outcome results. We should control edema, because when you have edema condition, you have pain and forced equinus foot, and the problems with active weight bearing. By the way, about weight bearing, of course, 1st, 2nd day after surgery, patient should walk with a walker or with crutches, but next, after 1 week, it is necessary to walk independent. and make his rehabilitation active rocking movements of the ankle joint and joints of the foot. Why we're talking about independent walking? Because gait video analysis in biomechanics says us it is just a better function of the operated limb without any crutches. So, conclusion, I think it is the best method in the world to treat neglected cases of syndesmosis injury. Thank you for your attention, and you are welcome in our conference at June. Thank you.
Thank you very much. Next, I would.
What do you do if you have some injuries of the ligaments? Please, do you do some ligaments, plastics, or transference, some with ligaments? What is the work? How you work and what you do with ligaments?
You mean a lateral, a prostrom gold procedure combined with an Elizarov technique. The goal of it to avoid cast immobilization and active motion, range of motion. So in case of neglected or failed previous ligaments surgeries, we do a plastic by half tendon of long peroneus tendon into lateral malleolus. So we have two types of surgery. One is just anchor fixation and prostrom hold, and the second one is true real plastic, combined of course with the Elizarov method for the same purposes.